Hello, my name is Dr. Higgins, and I'm a radiation oncologist at Winship Cancer Institute of Emory University, specializing in thoracic malignancies. The standard of care for limited stage small cell lung cancer has remained consistent over the past several decades. And what that is concurrent chemoradiation. Chemotherapy is typically platinum and etoposide, either cisplatin or carboplatin, for 4 cycles. And thoracic radiation is given either concurrently with the chemotherapy or coming in with the second dose of chemotherapy. In terms of the way that the radiation is given, there are 2 different regimens that can be used. You can give thoracic radiation once per day for about 6 to 6.5 weeks for a total radiation dose of 60 to 66 gray. Or you can also deliver radiation twice daily to a total dose of 45 gray. And what that does is it condenses the course of radiation and shortens it from 6 to 6.5 weeks to 3 weeks. And there's good data for that approach. That's also termed the PrecisCa regimen. That trial was shown to improve overall survival when compared to 45 gray given daily. But the question with the 45 gray BID versus 45 gray daily is really 45 gray daily is not a definitive dose that we would typically use in lung cancer nowadays with our improved radiation delivery techniques. So a large and very important trial was conducted in Europe several years ago called the CONVERT trial. And what that trial tried to understand was, is there a difference if you give the radiation twice daily to 45 gray versus once daily to a higher dose to 66 gray? And that was a anxiously awaited trial because it would really answer the question of the utility of the twice daily radiation. And practically speaking, it can be difficult at times to deliver radiation twice per day if patients are working and are busy throughout the day. And even just from a logistical standpoint within a radiation oncology department, it can be difficult to make those twice daily schedules. And so what that trial showed was that there was no significant survival difference if you gave the radiation twice daily versus once per day to that higher dose of 66 gray. And importantly, there were no differences in high-grade toxicities between those 2 radiation treatment regimens. Now, in North America and in the United States, 45 gray given twice daily is not used very frequently. It's only used about 10% of the time, primarily because of those logistical issues that I mentioned. But I would say right now, the standard of care is chemotherapy with concurrent radiation. Again, the radiation can be given twice daily to 45 gray or once daily 60 to 66 gray. After the thoracic radiation and chemotherapy is complete and staging studies are performed, if patients have no evidence of progressive disease, prophylactic cranial irradiation remains the standard of care as a next step. And that's typically given in about 10 treatments to a total dose of 25 gray. And that radiation dose is a lower dose than what you would use for a patient with small cell lung cancer that had known brain metastasis. So it's, I think, potentially less side effects than that higher dose that you give for radiation in the brain for known cancer there. There's also new techniques that we're doing to sort of reduce the risk of side effects with PCI, including certain drugs that can be given with the radiation, as well as potentially avoiding the hippocampal area of the brain when the PCI is delivered. And that's the standard of care right now for limited stage small cell lung cancer. And with that approach, concurrent chemoradiation followed by PCI, long-term survival at about 5 years is between 25 to 30%. And that's similar to what we had seen in 5-year survival for non-small cell lung cancer stage 3 patients before we started using immunotherapy. We are starting to look at immunotherapy in small cell lung cancer and limited stage disease. There are several trials right now underway that are assessing the use of immunotherapy, both in the consolidative setting as well as in the concurrent and consolidative setting. One of those trials is the Adriatic trial that gives immunotherapy after radiation and PCI is complete. And then there's NRG-LU005, which is giving atezolizumab during the concurrent and adjuvant phase of radiation treatment. And those will be important trials to see if there's any improvement in survival as we look at using immunotherapy in earlier stages of small cell lung cancer.